Thank you everyone for joining. We will start in the next minute or two, but we really appreciate everyone's time to logging in. And I am Dr. Koketso Pule. I'm a gynecologist based in Johannesburg, and I particularly have an interest in endometriosis and minimally invasive surgery. And with that, I've taken the interest to be active on national boards, the World Organization for Obstetrics and Gynecology, and I really advocate for trainees, for education, not just for young trainees or young specialists, but also for patients. I believe that empowered patients make better decisions regarding their own health. So we are very honored to have Dr. Herman, who's all the way from India on this call. And we will delve more into his biography once gives us a go ahead to start the webinar. It looks like we are having a great turnout, so thank you so much for taking time out of your evening to join this live.
Good evening, everyone. I hope you are all well. We have officially started the broadcast on YouTube. Thank you so much. My name is Busisiwe Mahlare, and I am the founder and CEO of RODI Wellness. For those who don't know my story, I got diagnosed with endometriosis at the age of 16, and that was my journey that was just the beginning of my journey. And it was quite a difficult journey. And just to summarize, I've been there with the period pains, the painful period pains, unable to get out of bed, sometimes laying on the floor, trying to just get relief from the cold floor. I've been there with the throwing up, getting chills. I remember there was a particular time where I actually had skin lesions coming out and my body was just fighting itself. And I've also been through like quite a lot. And just that's just briefly my story, just so that you can relate and that you know that I'm sitting from a perspective of I have been there. And right now I am symptom free. And part of the reason why we're having this webinar today is to give people hope and solutions or treatment options rather, because Dr. Google, as one of our attendees spoke about, actually tells you that it's the end of the world. So today we wanted to give you another perspective from a medical perspective and a journey that I've also lived, so a lived experience. I hope for those who've been through, going on this journey and have been on this journey for a long time, that you come with a fresh and open mind to learn and listen. I remember I used to feel like I have tried it all and I know it all, but guess what? I didn't. And now I feel like one of my purpose is to bring hope and to bring people solutions and everybody's journey is not the same. So I want you to please approach this webinar with an open mind, willing to learn new things, and please ask questions as much as you'd like to. And please let's make the most of this. We are joined by Dr. Koketso, who's my co-host this evening, and she will also be maneuvering and explaining to us the medical side of this disease and also the presentation. She will also be touching on the presentation that Dr. Herman will be delivering for us. And yeah, I hope this will be quite an informative session. And then I would just like to also say thank you so much, Dr. Herman, for joining us all the way from India. He's an expert in the field with endo. So we're quite privileged and honored to have you on this webinar this evening, where you just avail yourself to come and speak to us at a level where we can actually understand and make better choices. So thank you so much for this opportunity. Ladies and gentlemen, I hope that you get the most out of this session and that you go out empowered and ready to empower others. So for our patients, I hope that you come with a fresh perspective that you know what, you're willing to take in empty your cup this evening and actually take in information. And to our doctors, we hope that you will also just be open-minded and learn also from this session. And I hope that this session brings it becomes a bridge between the patient and the community together with the doctors, and we can come together and create an atmosphere where we can learn and heal. So now over to Dr. Gogetso, and she will be introducing our special speaker.
Good evening again, colleagues. I will just introduce Dr. Herman. Dr. Herman Ganojia is a pelvic endoscopic surgeon, meaning that he's a gynecologist with a special interest in endometriosis, fertility, and keyhole surgery for our patients that are not privy to what endoscopic surgery may be. He is practicing exclusive gynecological endoscopic surgery since 2001. So he's been practicing this keyhole surgery since 2001. So he's very experienced within this field. He has a special interest in minimally invasive surgery for deep infiltrating endometriosis, meaning that the least invasive form of surgery. So that's the keyhole surgery and your advanced endometriosis. And he's running a fellowship or mentorship program themed conceptual learning of gynecological endoscopy. So for the healthcare professionals online, if you Google him, find him online. He is running these fellowship programs and mentorship programs. So if you're interested, do reach out to him. He has an honorary pelvic endoscopy. He's an honorary pelvic endoscopic surgeon for complex gynecological endoscopic surgeries at the Ministry of Health in Kuwait. And he's a visiting consultant at various corporate hospital and fertility centers. He's an expert honorary visiting consultant at the RN Cooper Hospital in Mumbai, and he's also expanding into Dubai. So he's a world-renowned surgeon, and I'm certain that if we do reach out to him, he'll be happy to impart the knowledge that he has onto his patients and for us. And for those joining, I understand there may be healthcare professionals on the call, but for sensitive viewers, he may share sensitive images of endometriosis or endometriosis surgery. But this is to empower you as a patient or someone who may be going through this condition. And if we are going to be doing any form of surgery for you, we may share images with you to explain the disease process to you. But if you are a sensitive viewer, I will hope that we may give you a cue to look away if you are easily squirmish. But Dr. Hermit, I will hand over to you, and we look forward to this presentation and the interaction and questions that will follow after this. Please, you can start your presentation.
Thank you. Thank you so much, Dr. Koketso. Am I clearly audible? Can somebody give me a heads up? Am I clearly audible?
Yes, you are.
Yes, you are, Dr. Hermit.
Yeah. So good evening to everyone in South Africa. It's a real pleasure to be here with all of you online, virtually. And first of all, at the outset, I'd like to thank Busisiwe for getting in touch with me online. We have never met in person. It's only virtual contact and taking this initiative and giving me this excellent opportunity to present my point of view on endometriosis, since I'm an endometriosis expert. And I also thank Dr. Koketso for co-hosting this. So I'm going to keep it simple over here. So I'll just try to my screen is not moving ahead. So yeah, okay. Yeah, there you go. So, endometriosis, it's a very, very, very complex and enigmatic disease. As I take you through the course of this lecture, you'll realize even more why it is so. And Busisiwe was mentioning that, Google says it's end of the road, but believe me, it's not. Okay. The journey is difficult, but we try to make it as simple as possible because it's a complex disease. So here you can see how this endometriosis, it's everything is stuck inside. It causes something known as a frozen pelvis. So it can actually freeze the cognitive ability of the surgeon in the operation room if one is untrained to deal with these kind of situations. So training is important. So now taking you through the basics, because we have a blend of gynecologists and lay people or common people. So we'll try to balance it out. So the question is, what is endometriosis? Now we all know that endometriosis is presence of endometrial-like tissue that could be glands and stroma, which is the lining of the uterus, which is present in the cavity of the uterus, which is called as endometrium. But when a similar tissue is present at abnormal locations outside the uterine cavity, it is known as endometriosis. But listen to what I said. It is endometrial like tissue. It is not similar or the same thing as the endometrial lining. And this is very important as a concept, as a principle of treating endometriosis, as you will see as I proceed through the course of this lecture. The incidence we all know is like 1 in 10 women, but now the
Huh?
current data suggests like it's 1 in 7 women.
Simon, if you're going to
And the
rest,
worldwide incidence or
got
the
it.
worldwide total number of females suffering is up to around 200 million. And that's a massive number all over the world. And what we have seen that over the last decade or so, over the last 15 years, the age group is coming down. We are seeing a lot of adolescent girls, suffering from severe form of endometriosis right after their menarche. Menarche is something which is known as the beginning of the period. When your period starts, it's known as menarche. So, seeing a lot of young girls in the age group of 16 to 25 suffering from this disease. Typically speaking, this disease was known in for the reproductive age group that is from 25 to 45 onwards, but on both sides of the spectrum, that is the young girls and even the postmenopausal females are seen suffering from endometriosis. Now, it's a hyperestrogenic state. Now, there are two hormones in the female body mainly. They are the estrogen and the progesterone, which vary during the cycle or the hormonal state of the month. So, here typically there is an estrogen dominance, and that is why this endometriosis tissue grows in that hyperestrogenic state, and which also leads to chronic inflammation within the body. And you'll see this hyperestrogenic state also is responsible for something known as polycystic ovarian disease or PCOS, and also known to cause fibroids. So these conditions like endometriosis, PCOS, and fibroids can coexist in around 40 to 50% of cases. And grossly speaking, endometriosis is a multi-systemic disease where there is neuroimmunomodulation. So right from the nervous system to the immunological system is affected. And that's why it's a very complex disease. So there are a lot of theories for endometriosis, but even after 100 years, when the name was first coined or the disease was invented, we still don't know the actual reason why endometriosis takes place. There's a lot of research going on at a molecular level. The most favorite theory was retrograde menstruation, where the menstrual blood was flowing towards the abdominal cavity during the menstrual phase from the fallopian tubes, and the menstrual blood was responsible for endometriosis because the endometriotic tissues would go and stick into the peritoneal cavity or the abdominal cavity. But this is a very old theory and it's been debunked. It did not stand the test of time. Then there are many other theories like transformation of the peritoneal cells into the endometriotic cells. There is surgical scar implantation after cesarean sections. You can see in the scar or in the cesarean scar, you can have endometriosis. Then it is also known as an immune system disorder where the macrophage function is affected. The macrophages are the cells which actually eat up the cells which are not required in the body, like the endometrial cells, which may go out in retrograde menstruation. So when the macrophages are deficient in their function, these cells can get implanted. They don't get cleared out of the abdominal cavity and they can cause endometriosis. But the best theory that now actually seems logical is known as the theory of mulariosis, where there is abnormal differentiation and migration of the cells during the embryonic phase. So it actually happens when the child is developing in the womb of the mother. And this theory actually logically tells us why endometriosis is found in regions outside the pelvic cavity also. So that is abnormal differentiation and migration of the cells, because as you see the genitourinary tract, when it develops from higher up in the body, and then it moves towards the pelvis. So it leaves these crumbs of endometrial cells along the line, and these crumbs of endometrial cells, which are left behind in an abnormal fashion during migration, is the reason why we see endometriosis outside the pelvic cavity in regions like the diaphragm, the lungs, and many other places like the intestines. So this theory was strongly supported by Dr. David Redwine, a strong proponent of excision surgery for endometriosis. So if you see the entire theory, retrograde menstruation, because almost all females are going to have retrograde menstruations, but all don't develop endometriosis. So there could be a lymphatic spread also. I told you about the mulariosis, which is abnormal differentiation and migration of cells, surgical cause due to cesarean sections or metaplasia. There is also a differentiation in the receptor behavior in endometriosis. So normally the endometrium or the estrogen acts on the alpha receptors, but in endometriotic lesions, there is a predominant of beta receptors, because of which there is de novo production of estrogen. There's another theory of gut microbiome. Most of you who are on the net researching for endometriosis would have heard about gut microbiome. Gut microbiome is the flora of bacteria that is present in your intestine. And when this gets altered for some reason, the estrogen metabolism is affected and there is a predominance of estrogen in the body. So a lot of therapies are now focused on gut microbiome, and there's a lot of research going on in that direction too. Again, in the last couple of years, we have seen an exponential rise in endometriosis. One of the factors could be environmental contaminants, something like phthalates, even products. There could be some products in the cosmetic that we use, or personal care products, which could be responsible for this. So there is a, a array of things that is responsible for endometriosis. There is a genetic cause, there is immunomodulation. We told you about the gut microbiome. There could be dietary factors which can affect hormonal factors like estrogen predominance, environmental factors, and epigenetics, which is different from genetics. Now, epigenetics, there is a difference in expression of the genes. There's no mutation in the genes, or the genes are the same, but how the genes express or act to a receptor is different from normal. So what are the risk factors for endometriosis? A nulli gravida who's not had children at all, because see, the entire thing is, it is hormone dependent disease. Every month there is estrogen and progesterone that is going up and down in a cyclical manner. And your endometrium lining responds to those hormones. And if you don't have a pregnancy, it is shed off as a menstrual blood. Now, similarly, the endometriotic lesions which are present outside the uterine cavity also respond to these hormones in a cyclical manner. And there is bleeding from these nodules also, but these bleeding don't have an outlet. They remain localized, because of which they produce inflammation and all the organs stick to each other. So the more number of cycles a female is exposed to, the menstrual cycles, the more will be the chances of having endometriosis. So a female who doesn't have any children will have more uninterrupted cycles, because a pregnancy is where the cycles are interrupted, or so the endometriosis can become silent. But pregnancy is not the cure for endometriosis. It is just a stopgap. It may give you temporary relief because there's no hormonal activity taking place, as there's no menses during pregnancy. Again, early menarche, because you're getting your period at an early age. Late menopause, again, more number of cycles you've been exposed to. Shorter menstrual cycles, like frequent cycles. Heavy menstrual periods can be a cause. Having higher levels of estrogen in the body, so greater exposure to estrogen, as these are estrogen dependent lesions. Yeah, obviously there is a genetic tendency. First degree relatives are more common to have it. Risk of endometriosis is 6 to 9% higher in first degree relative of women with endometriosis, and 15% higher when they have had a severe form of disease. So family history is important. Any medical condition that prevents passage of blood from the body during menstrual periods. So you could have some obstruction in the reproductive tract, where some septum or something which does not prevent, which prevents the menstrual blood from flowing out. So there's more of retrograde menstruation, and that is known as the disorders of the reproductive tract. Now, the clinical presentation is very important because this can be a clincher for the diagnosis of endometriosis, actually. So there's a classical triad of dysmenorrhea, dyspareunia, and deep pelvic pain. These are the Ds which I tell my students to remember. So dysmenorrhea is painful periods, dyspareunia is painful sexual intercourse, and deep pelvic pain, which can last during the periods or in between periods too. Now, deep dyspareunia is due to stretching of the involved scar tissue because there is endometriosis within the pelvis, and because of the sexual intercourse, there is a lot of pain because the lesions are just above the vagina over there. Then obviously there are other Ds also like dyschezia and dysuria. Dyschezia is when you have painful passage of stools, and dysuria could be painful passage of urine when the urinary tract and the bowel are involved. We have to understand that the intestines and the bladder are very close to the uterus in the pelvis. And this is a locally invasive disease which can spread on to the nearby critical organs. There could be also abnormal bleeding like heavy bleeding during the menstrual cycle. And infertility is quite commonly seen with endometriosis. So, as I told you, this is a symptom list, which I told you the Ds. Okay. And now, according to the recent ACOG or the American College of Obs and Gynec Society 2026 recent guidelines, which are in the Feb of 2026, any one persistent symptom is a red flag. If out of these, if you have any one symptom which is persistent, then it requires a detailed evaluation. This is a big jump from the previous guidelines, which used to rely on specific diagnosis like laparoscopy diagnosis, and because of which the diagnosis was getting delayed. So now it's a symptom-centric diagnosis. And definitely there will be definitely signs like pain in the abdomen, which a physician will pick up. So the issue is now when they have pain, they could be painful periods, painful intercourse. Now, it's very difficult to quantify pain because pain is a very subjective thing. So, we have this visual analog score or a score on 10, which helps us to quantify pain because it gives us an idea about how much the patient is suffering. So, when the patient says that any pain more than 7 to 8 is a red flag, because almost 99% or everybody, all females are going to have painful periods, some amount of pain. So how do you pick up severe pain? You have to quantify it. And when it is severely debilitating pain, which affects the daily routine of a female or a daily function of the female, then it is a red flag and it needs to undergo a detailed evaluation. Now, what is the impact of endometriosis on fertility? This is very important because 40 to 50% of females with endometriosis are going to have fertility issues. Now, why is it so? Now, we know that this is a chronic inflammatory condition. I told you there is microbleeding happening inside because the nodules bleed in response to the hormones. This microbleeding over a period of time causes inflammation where the organs stick to each other and they produce a lot of oxygen-free radicals, which are inflammatory things. There are a lot of inflammatory markers also. This in general affects the milieu of the pelvis due to chronic inflammation. Now, the ovary is also affected with endometriosis, known as a chocolate cyst, as I'll show you as we proceed in the presentation. Now, this affects the ovarian reserve. Ovarian reserve is nothing but it's like a fixed deposit you have in an account or bank account where you have fixed number of eggs which are going to produce your future pregnancies. So every ovary has a reserve. And because of this chronic inflammation within the ovarian reserve is reduced over a period of time. And even the quality of eggs that are produced are very substandard. So this is how endometriosis impacts fertility. And definitely fertility enhancing surgery and excision surgery are known to improve conception results either naturally or through assisted reproductive techniques. One thing we need to understand is the psychological impact of endometriosis. It's one disease which causes severe psychological implications. Why is it so? Because of the severity of symptoms like severe debilitating pains, which affect the quality of life, the propensity to being dismissed even by medical professionals. Then this leads to confusion and lack of clarity in the female's mind as to what is happening to her. Why is she suffering from so much pain? Then there once even when the diagnosis, and mostly it's a delayed diagnosis, it could be followed by a complex surgical treatment, which again leads to anxiety. It's a chronic condition which can last for prolonged duration and thereby produce psychological implications. It affects intimacy because of painful sexual intercourse, fertility issues, as I told you. The productive life of the female is affected because of missing out on, say, college, school, or her workplace. And definitely social interaction because of this chronic pain is also affected. So, in all, it has a tremendous psychological impact. Now, what are the problems in dealing with endometriosis? The main problem is the early diagnosis. Now, why is it that it's not diagnosed early? Because there's a lot of overlapping of the physiological symptoms. As I told you about painful periods. Now, I told you every female has painful periods. So it's very difficult to know that this period pain is endometriosis related and not physiological. So that's why it probably gets dismissed over a period of time and it's taken as a norm that every female has to undergo pain during period. It's a progressive disease where it is locally invasive. As I told you, it has a propensity to invade into the nearby critical organs like the bowel, bladder, and the ureter. Now, even professionals are not trained to pick up the early signs, and this is because it's not the fault of the professionals, because the professionals, even most of the OB-GYNs were not trained specifically to pick up endometriosis, and that's why endometriosis needs to develop as a subspecialty, which is completely focused on endometriosis. Because of this lack of clarity, there's a lot of gaslighting, the symptoms are dismissed, and there are also gender and racial biases as seen by various studies. Now, screening is a thing where probably we can pick out many diseases, like, say, cervical cancer, but that's not possible with endometriosis because there's no specific test which can pick up endometriosis. There are a lot of things in the research phase right now, but there's nothing where we can screen and triage patients for endometriosis, which again is the major cause of delayed diagnosis. Now, the delay in diagnosis can be anywhere from 7 to 11 years or even more. As I told you, it's a progressively locally invasive disease which is affecting the quality of life. There is a tendency to overuse and abuse hormonal suppression, that is medical management, even when it is not working. It is definitely the first line, but when it is not working, when the symptoms are refractory, we need to go to the next level rather than just sticking to the same old prescription. There is surely a dearth and shortage of experts to understand the disease and even to surgically excise and manage the disease. And this is a global problem. Believe me, this is not a problem of the third world countries or developing countries. It's a problem of the developed countries and even in the Western world. It's a global problem. There are long-term morbidity associated with either residual disease because of incomplete treatment or incomplete surgery, because of recurrences. Whatever said and done, you cannot remove endometriosis 100% from the body because it's a tendency, it's a predisposition. So recurrences, chances of recurrences are always going to be there. And long-term morbidity could be post-surgical also due to complications. And till date, there is lack of adequate funding, research, and awareness also as far as endometriosis is related, as far as endometriosis is concerned. And that is why we need to create more of these kind of global interactive sessions to create awareness of the disease. It's still better than what it was, say, probably 7 to 8 years back. There's a lot of awareness being created on social media. And obviously, there are two types of awareness. One is good awareness and bad awareness. And we, as patients and as consumers, need to vet out, what is good for us and what is bad for us. And all our understanding of the disease should be based on scientific evaluation and not on hearsay. So, what are the site of endometriosis? It could be anywhere in the ovaries, it could be all around in the pelvis. The ligaments which attach the uterus, like the uterosacral ligament, over the intestines, over the urinary bladder. And when endometriosis is present within the muscle layer of the uterus, this is the lining. This is the lining where you have the endometrium, which responds to hormones. And when this endometrium like tissue is present outside, is endometriosis. But when it is present in the muscular wall of the uterus, it is known as adenomyosis and is also known as the twin evil sister of endometriosis. But we are not going to touch too much on adenomyosis today because that's a different topic by itself. So, what are the types of endometriosis or the phenotypes? They could be pelvic and extrapelvic endometriosis. The pelvic endometriosis just related to the superficial peritoneal surface. Now, peritoneum is a layer which is lining all the organs in the abdominal cavity. So it could be just superficial peritoneal endometriosis where it is infiltrating less than 5 to 7 millimeters. It could be within the ovary, which is known as the chocolate cyst because there's a chocolate colored fluid within the ovary because the same nodules are bleeding within the ovary and causing that chocolate color fluid. It can be deep infiltrating endometriosis when the depth of infiltration of the lesion is more than 7 millimeters or 5 millimeters. Adenomyosis, I told you, that is endometriosis within the uterine musculature. It is also responsible for heavy bleeding and also for severely painful menses. The extrapelvic endometriosis can be in the gastrointestinal tract, that is the rectum, sigmoid, in the urinary tract, the bladder or the ureter. Scar endometriosis is usually seen post cesarean because when we do a cesarean, we are opening the uterine cavity to deliver the baby out. And there is a theory which says that the endometrial cells spill out and they could implant on the scar of the cesarean section just below the skin in the layers of the abdomen and later on respond to hormones and proliferate inside to lead to scar endometriosis. Endometriosis can be in the vagina also, and in thoracic endometriosis, there is involvement of the diaphragm and the lung and pleura also. So, how do you make a diagnosis? So, as I told you, there is usually a delay in diagnosis because of the various reasons that I mentioned before, and there is a lack of screening modalities, but there are a few things that are coming up in the market. There is a saliva test known by the name of Zigwig, which is a good marker for screening. There are blood biomarkers. The essence of all these tests is to pick up specific mRNAs at a molecular level so as to diagnose the disease or the probability of the disease progressing in a patient and triaging them. But the best form of diagnosis in the current era is by imaging. By imaging, it could mean a good ultrasound or a good MRI of the pelvis or the abdomen. Now, imaging is very important. In the last few years, it has picked up immensely. The first line of imaging, even the ACOG recommends now, is an ultrasound. But it's not only that you need to do a routine ultrasound, this is a specific ultrasound where there is an endo mapping done, which acts as a GPS within the pelvis and guides the surgeon during surgical management. So the entire pelvis is evaluated in a compartment-wise manner, the anterior compartment, middle compartment, posterior compartment, and the lateral compartment. But the ultrasound is operator dependent. You need a person who is trained in doing ultrasound for endometriosis specifically, and routine radiologists are not well equipped in doing that. So you can't do an ultrasound in say 5 minutes and do a imaging for endometriosis. It requires a detailed evaluation over 20 to 30 minutes to see the entire mapping of the disease. MRI is also one of the best tools, but it is definitely more expensive and not so accessible. So ultrasound is definitely the first line. But once you diagnose deep disease, one can confirm with MRI to see the extent of the disease and for better mapping because MRI gives you definitely better resolution, not very much operator dependent because those are standard images. But all these images depend or are open to interpretation by a radiologist. So you need a good radiologist or a clinician to interpret and put them on paper. So these images act as a GPS for the surgeon when they are operating, and we heavily rely on these in performing a optimal excisional surgery. Previously, laparoscopy was considered as a gold standard for diagnosing endometriosis, but it's an invasive procedure in terms of giving anesthesia, getting the patient admitted, going to the OR. So at the moment, laparoscopy is definitely not the gold standard for diagnosis. It is definitely the gold standard for treatment and surgical excision of endometriosis. So to take you through a couple of videos, I'll run you through a couple of videos. So here you can see a normal video. I've deliberately showed a normal video for our patients or those who are curious, who are non-medical professionals. So here you can see this is the uterus, that's the intestine, the rectum and the sigmoid, both the ovaries and the tubes, two ovaries, two tubes. You saw how the entire region over here between the tubes, between the uterus and the intestines is absolutely clear. See, there's a nice distance over here between the two. This is how it normally looks in a pelvis. Okay, that's the uterus. In contrast to this video, now you can see over here, this is the uterus. You can see everything is stuck over here. All the normal planes are obliterated. There is complete anatomical distortion. You can see the rectum is stuck to the uterus over here. There's no plane in between the two. And that is how the disease invades. And this is the final surgical picture after surgical excision. You can see all the near normal anatomy. We can't create the normal anatomy as God does it, but we can create near normal anatomy by optimally excising all the endometriosis. So there you go. So now you can see over here again one more small video. Uh, So here you can see this is the ureter, which is involved in endometriosis. That's the uterus. Again, the rectum and the sigmoid are stuck over here. See how the disease is infiltrating into the sideways or into the lateral compartment towards the ureters. These are all the nodules that we are excising. Nodules are nothing but literally fibrosed, almost stony hard tissue which we need to excise because this is the one which causes fibrosis. It causes pressure on the nerves. You can see the nerve over here. This is known as the hypogastric nerve. It causes pressure on these nerves, which is the cause of pain, autonomic dysfunction. And this is the nodule at the torus and the topmost portion of the vagina, which is responsible for dyspareunia or painful intercourse. Here you see how we are saving the nerve. So in these surgeries, we have to balance out excision along with saving the function of the organ, because this is ultimately not cancer where we can compromise the function of the organ. These are benign diseases, but they are invasive also. So we need to strike a balance between optimum excision and saving the function, because if I excise or cut this nerve, the autonomic dysfunction, that is the bowel and the bladder function in the post-operative period, will be affected. And this is the job of an endometriosis excision surgeon. Okay, it's not that everybody can perform these surgeries, and it's not that one cannot learn these surgeries. One has to focus, hone their skills, know the anatomy properly, and then attempt these surgeries in order to do justice to the case and to give good outcomes to a patient in terms of improving their quality of life. So these are all the nodules that are being excised. So by optimally excising the nodules, we are reducing the inflammatory load of the disease and thereby improving the quality of life of our patients. So this one is the typical chocolate cyst which you see. As I told you, this is the ovary over here. It's a huge ovary. It's at least 3 to 4 times enlarged, and you can see the chocolate material coming out. This is ovarian endometriosis, and here we are sort of removing the cyst wall, and a well done cyst wall removal definitely reduces the chance of recurrence. But obviously, the fertility potential also of these patients get compromised in terms of pregnancy outcomes. But if you do a good technique and good method of excising these cysts, the results are quite good in terms of pregnancy. Here you can see some subtle lesions of endometriosis over here in the early stage. These vesicular lesions, these colored lesions, they could be powder burn lesions or red colored lesions. There are various phenotypes of the disease. But this is how we pick up the subtle disease. And this is a pointer that they might progress in the future to a severe form of disease. So here is an MRI image. Look at the resolution. This is the nodule over here. You can see there are a lot of these white spots are the hemosiderin pigment, which are the blood collections over here, which give rise to severe pain because they don't have any outlet. This is the entire uterus. See the kind of resolution that is seen in MRI, and that is a bowel wall nodule which is infiltrating into the bowel like a mushroom. So the treatment of endometriosis, this is very important. See, endometriosis is, I told you, a very enigmatic disease. The clinical findings or the surgical findings may not match up with the symptoms of the patient. So the patient could be having a excuse me, a mild disease, but lot of findings inside, and hardly any findings, or mild findings, but lot of symptoms. So the entire treatment of endometriosis is centered around the symptom of the patients, what we call as a symptom-centric approach. For that, we need to listen carefully, intently to the patient because the history is what gives us a lot of how we are going to manage this patient. Ultimately, the options need to be explained to the patients in terms of outcomes, the pros and cons, and we need to follow the process of shared decision making according to the goals of the patients, the desire of the patient in terms of pregnancy, in terms of quality of life. And that's why it's a complex this, because there are a lot of gray zones over here. It's never black and white. So what are the options that we have at hand? Excuse me. So you have the medical management, which is definitely the first line in terms of hormonal medications. So the entire principle over here is to suppress the hormones within the body, or something known as the hypothalamic pituitary axis, which once the hormones are suppressed, there's no stimulation of the nodules or the endometriosis lesions, and they become quiescent for some time. But once you stop these hormones, they are going to come back, either in full force or in a lesser form, but the disease is definitely, and the symptoms are going to come back. So this is just to buy time. It's not the cure, especially for severe form of disease. So hormonal medications could be oral contraceptive pills. You have Dynogest various progesterones. You have the GnRH central blockers like the Leuprolide. You have progesterone containing intrauterine device like the Mirena, which you can put in the uterine cavity, which releases progesterone. Progesterone is like an antidote for estrogen. So it will suppress the estrogen and it will prevent the estrogen from acting on the endometriosis lesions, thereby making them quiet. Definitely, you have to give something for pain management also, but it is important that you control the amount of painkillers that you're taking in endometriosis, because we have seen a lot of patients taking high doses of painkiller medicines and over a period of time landing up with kidney problems because of chronic abuse of painkillers. It's very important that you take it under medical supervision. Surgical management, as I told you, is symptom centric, depends on the age of the patient, the desire for pregnancy, and the severity of the disease. Obviously, after surgery or before surgery, there are some complementary therapies also, like functional medicine, dietary nutritional therapies, exercise, yoga, and many other things which act in a complementary manner, but they are not the mainstay of therapy. So, because I see on social media a lot of people pushing forward some form of complementary treatment as an alternative for surgical excision, okay, or for surgical treatment. That definitely won't work in severe form of disease, maybe in early phase of disease or post surgery. If you need some backup, it may help, but don't try to replace science or scientific, backed evidence with complementary therapies. So, as we know, it is a deep disease. So, what we see is just the tip of iceberg. And this is the principle that we follow during surgery. Because what you see on the superficial side of the disease is just the tip of the iceberg. There's more disease lying below. And that is the reason, as you saw in my video, we were excising the disease and not just superficially burning the disease, which was done in the earlier days. If you just superficially burn the disease, you are not removing the disease from the root, and the chances of recurrence is going to be high, and the patient's symptoms are mostly not going to improve. So, excision is the way for deep endometriosis. What are the indications for surgery, or is surgery the only option for all? Definitely not. Being an endometriosis surgeon myself, a hardcore surgeon, I don't say surgery for all. There are specific indications where there is refractory disease, refractory to medical management. It is progressive over a period of time as you're monitoring on imaging in terms of symptoms and in terms of morphologically or anatomically, also the disease is progressing when there is severe, uncontrollable, debilitating pain. We have had patients who have been suicidal. They tell us if you don't operate us before our next cycle, we'll probably commit suicide. That is the kind of desperation they have. When the critical organs like the bowel, bladder, ureter, they sometimes these critical organs can be silently affected. They may not be producing symptoms like one side of the ureter is affected or one side of kidney is affected. So the other side of the ureter and kidney will compensate. So the affected side of kidney can silently undergo death also. So in those critical cases, you need to go in for surgery in spite of the fact that the patient may not be having too many severe symptoms. I told you about progressive disease. Now, the surgical management is definitely, there's a term for it known as a radical excision of endometriotic implants. Now, as I told you, this is the optimum debulking of disease. Okay, it could be either with conservation of uterus and ovaries, as the patient may seek fertility or the patient is young, or it could be complete removal of uterus and ovaries, depending on the age of the patient and the desire for pregnancy. This has to be done only by a specialist endometriosis excision surgeon for a better outcome, and it has to be done along with a multidisciplinary team. As you know, multiple compartments are involved, multiple organs like the bowel and bladder. So you might have to take inputs from your friends from different specialties like colorectal, urologists, neurosurgeons, thoracic surgeons if the diaphragm is involved, and to give their inputs as to management of this disease. But the in charge is the endometriosis specialist because nobody understands the disease better than an endometriosis expert. Post-operative period patient may require temporary medical management. The important word is temporary medical management, because any prolonged medical management is going to give rise to hormonal side effects. The temporary medical management is only for temporary suppression till the tissues are healing. And there's also role of pelvic physiotherapy because the muscles are tense over there, the nerves are affected. So pelvic floor physiotherapy also is a complementary kind of treatment. Role of alternative treatment, as I mentioned, is complementary. So why is surgery for endometriosis expensive? This is most common question which comes to the mind of our patients. We have to realize that it's a complex surgery. Okay, it's a multi-organ disease, multi-compartment involvement, a multidisciplinary approach. There are complex procedures that might need to be done on the bowel, like a part of the bowel might have to be removed along with stapling. A part of the ureter might have to be removed and reimplanted into the bladder. And it's not just a simple cyst removal. Okay, like if you have an endometriotic cyst, there is 40 to 50% chance that the lady will be having accompanying deep endometriosis. So if somebody is untrained and just does removal of the cyst, then the symptoms will not go, the recurrence chances will be high, and the disease will come back. So along with the cyst removal, you have to do the excision of deep endometriosis also. Similarly, it's not just a simple hysterectomy, because simple hysterectomy is not the answer for deep infiltrating endometriosis. Along with the hysterectomy, you have to do a radical excision of the endometriosis all around the pelvis to completely reduce the load of the disease. Now, even after surgery, sometimes you may have persistent pain. This is due to the fact of centralization of pain, or a term known as central sensitization of pain. And this also happens because the disease has been neglected for long and not managed in the early stage. And because of this chronic duration of the disease, there are pain pathway tracks which fire impulsively or activate spontaneously even after the physical source, that is the disease, has been excised and removed, because there's a lot of pain fibers which have been stimulated over a long period of time, and they just keep on firing after, even after the disease has been removed. So this is a known term, and this is again the reason why we should not delay surgery when it is absolutely indicated. So these are the latest guidelines by the American College of OBGYN for endometriosis, just released on, I think, in the month of February 2026, just before the endometriosis awareness month of March. So there is significant diagnostic delay. I told you 4 to 11 years. The traditional reliance on surgical findings to diagnose endometriosis is an important contributor to diagnostic delay. So that's why I told you laparoscopy is not relied now to diagnose. It is mainly imaging. So the recommendation is to use clinical findings and imaging tests to provide a presumptive diagnosis. And with presumptive diagnosis based on the patient history, symptoms, physical examination, and the imaging, we can start also empiric medical treatment just on assumption. We can start treatment for endometriosis and then evaluate the patient, but we can start empiric treatment so that at least the patient feels better. But that doesn't mean once the patient feels better, she should be left alone. There has to be a detailed evaluation for endometriosis. Okay. Then we must enhance medical education and training on endometriosis. This is very important. Even the medical professionals need to be educated on endometriosis to understand the disease better, how it progresses, how it functions. And obviously, we need to, have some non-invasive diagnostic techniques like some biomarkers or some test where we can diagnose endometriosis better and faster. Then dismissal or invalidation of symptoms by clinicians can delay diagnosis. As I told you, a process known as gaslighting can have significant negative effect on people's psychological and emotional well-being, as we have seen so many times. And we must raise public awareness of this chronic condition as we are doing today, so that the individuals who present to clinicians outside of OB/GYN specialties can receive appropriate timely evaluation and refer to a specialist care without delay. This is important because some of these patients, they present only with urinary symptoms. They present sometimes with just intestinal symptoms and go to a gastrointestinal specialist. They don't know anything about endometriosis. And the patient gets just managed, dismissed off, or managed in a wrong manner, not because it is their fault, just because they are not aware about this disease. And that is again what leads to progression and delay in diagnosis and management. So finally, I'd like to conclude that endometriosis has these pillars, where we need to really screen the patients as far as possible. But our screening is at the moment based on a good history, the symptoms, and a good imaging. Early diagnosis, again, with good imaging. Either medical, definitely medical is the first line, but when they are refractory and when indicated in severe form of disease like deep infiltrating endometriosis, surgical management is the way. It has to be complemented by supportive therapy, as I told you, complementary therapy, and we have to do a lot of research on molecular level to get to the root cause of these disease. Obviously, the red flags are important in terms of history taking, as I mentioned, what red flags we need to look at. So with this, I'll conclude my talk. I hope I have made it quite clear in terms of how to deal with endometriosis and how to make this complex disease or simplify it as much as possible. Thank you very much once again for being here.
Thank you so much, Dr. Hammond. That was a mouthful, and I hope it seemed to have catered well to our healthcare professionals online and our patients. And I hope that the imagings were not too sensitive for them. But this is the reality of women living with endometriosis. You have to understand the disease, you have to understand the disease process. And when you understand your body, you're able to make informed decisions. So I hope for those who have sensitive eyes, those were not offending images, but this is the lived realities of many women. Okay, just to delve into it. So, Dr. Hammond, in terms of the incidence of endometriosis, in the past, young girls would get dismissed in terms of their period pains, and period pain is normalized. What has changed in terms of the age group where now endometriosis is common? As we hear from Busi, she was only 16 years old when she was diagnosed. Do you think it's
Yeah.
now more of the awareness, or has it always been the case that young people, young girls have also in the past experienced endometriosis, or has something changed within our environment or our diet?
Yeah, that's a very pertinent and good question. I feel it's a combination of both. I feel the incidence has exponentially increased. The age group has come down because in the last, I think, 2 months, I've had, I think, almost 10 girls whom I've operated in the age group of, say, 16 to, say, 22. And some of them are medical college or medical school girls. Okay, so definitely the incidence has increased. We don't know the cause. Okay, it could be an environmental trigger, epigenetics, we don't know. Okay, but the thing is, the incidence has increased. It could be also contributed by increased awareness and diagnostic modalities, but I have no doubt in my mind, based on my experience, that the incidence is increasing.
Okay. So in terms of the gut microbiome and its response, there's a lot about changing lifestyle and anti-inflammatory diets. Is there an
Yeah.
overlap in terms of inflammatory conditions of the bowel and the incidence of endometriosis, or the influence of these inflammatory bowel conditions on endometriosis, and how does the diet and lifestyle changes affect the progression of endometriosis or the risk of one having endometriosis?
See, definitely there is a link, okay, because there's something known as the estrobolome, where the estrogen metabolism takes place in the gut via the gut microbiomes. So, because of any reason in the intestine, which the gut microbiomes are affected, the quality is affected, it does affect the metabolism. And we have seen there's a lot of overlap of endometriosis with IBS also, because inflammatory bowel syndrome gets misdiagnosed with or overlaps with endometriosis symptoms, the same bloating kind of a feeling, nauseous feeling. These are all symptoms of endometriosis also. So it is imperative that we see a holistic picture and not just the pelvis in endometriosis. As I told you, it's a multi-system chronic inflammatory disease. It's even affecting the nerves. They say even the vagus nerve is affected because the vagus nerve controls the inflammation levels in the body. So now they are targeting the vagus nerve, where they can stimulate the vagus nerve where the inflammation or the chronic inflammation may come down. These are all the researches that are happening, and the gut definitely plays an important role. And if we can do something to manage that in terms of lifestyle, in terms of anti-inflammatory diet, I think everybody should be having anti-inflammatory diet for that matter. But it's a generalized lifestyle term, but if it can help you for endometriosis, I think you should. But it's not the mainstay therapy, as I told you. It is definitely a good complementary therapy along with either medical or surgical management.
Thank you. That was such a clear answer. But in terms of delaying diagnosis, I think most of the time is the problem with us as healthcare professionals not acknowledging our own limitations and not knowing when to refer. But now there's a pertinent question from one of our attendees asking, how long does it take to train a radiologist? I will add to that a gynecologist to detect deep endometriosis through ultrasound. What is the learning curve in terms of that?
So let me break it down for you. So let me tell you about the radiologist first, because that is a bit easier, because the learning curve is not so bad. Because if you're a you have a basic degree in ultrasound and a basic training in ultrasound, it is just extrapolating your knowledge in terms of focusing more on endometriosis. And it's just interpretation of images, which the more you see, the more you will start picking up, because the mind doesn't know what the eyes can't see. So, but if your eyes start seeing them, your brain starts picking them up automatically. So for the radiologist, definitely easy. For the surgeons, yes, there is definitely a steep learning curve that needs to be negotiated in terms of endometriosis. Because even if you're a basic laparoscopic surgeon, these are highly skilled procedures, okay, where you're dealing with a lot of critical organs, and the incidence of complications in an untrained hand is 10 to 20 times higher. Okay. Anyways, the chances of complications are high even by a trained person, because these are very critical procedures. There could be complications. But if an untrained person is doing it, it's 10 to 20 times more. This is what the study shows. So there is a steep learning curve, and that's why you have lesser endometriosis surgeons globally, because not everybody tries to go onto that path of focusing and giving that much time, coming out of your comfort zone to hone your skills to become an endometriosis surgeon, when you are never exposed in your training program, because most of the training programs don't give you endometriosis surgical exposure. So we are all self-trained people just out of interest over the period of time. We just focused our attention. Obviously, it was not easy for us, but now that we are into it, we are totally into it, and we are doing quite a good amount of justice to it. That is what is helping us. But I think it should come up as a subspecialty in the near future, or as soon as possible. So definitely a little more steeper for the surgeons, not so difficult for the radiologists. But I'm not saying that one can't learn it. Definitely, if one has the passion, the enthusiasm, and the will to do it, to go that extra mile, it is very much possible.
Thank you so much for that comprehensive answer. But just for our patrons and listeners online, um, can you just get into emphasize the difference between normal period pains that are considered physiological period pains and endometriosis pain? Because as you said, our pain thresholds are also different. And also
Yeah,
the burden of disease is not equal, does not necessarily
yeah,
give you a certain amount of pain. So can you just
true.
emphasize for our listeners what is normal period pain and
Yeah,
what is
yeah.
concerning endometriosis period pain?
So I'll tell you in a very practical manner. Suppose a patient approaches me. Okay, let's make it simple, because let's make it a story kind of a thing. So if a patient approaches me with an anamnesis or a history of painful periods, I'm obviously going to ask, the first question is, how much is the pain? So out of 10, if you want to score your pain, how much would you score it? If the patient says it's more than 7, it definitely rings an alarm in my mind. Then I ask her, is her routine activity affected by that pain? And she tells, I'm just in bed, rolled up, and I can't even move about. I have to take painkillers 3 to 4 times in a day. I can't attend school, college, work. I changed jobs because of this. I had to leave my job. It is debilitating pain that is affecting your quality of life. Okay, I've had canceled so many programs, so many interactions, so many social functions. All these things should raise an alarm and should make you investigate more and not dismiss these symptoms as, oh, you're a female, you need to suffer with this kind of pain. That's okay, it's part of your physiology. And that is where the delay in diagnosis takes place. Because see, normally I am a referral person, so I get only patients who have come with delayed diagnosis. And I really feel sad for them, in the sense that this complex disease could have been dealt with much earlier in a safer and better manner had somebody picked it up earlier. So I think this gives you a clear idea, kind of a thing. So once you have a doubt, then you should go all out to evaluate it with imaging. And sometimes the imaging might come negative, okay, in around, say, 4 to 5% of the cases, you may get the imaging, even the MRI normal. Then if the pain still persists, it warrants to put in a laparoscope also and see. There's no harm in that. But those are very few patients, but mostly you'll pick up some disease. Okay. And as the guidelines say now, you can start empiric treatment to decrease the symptoms, but continue with the evaluations. Very clearly said in the current guidelines, which was not done before.
Thank you so much for that answer. And speaking about laparoscopy and surgery, there's a question asking, what are the risks associated with excision surgery of deep infiltrating endometriosis that is particularly located in the
Everyone is
pelvis that is
right.
stuck together? Can you please mute? My apologies. So, what are the
No
risk
problem.
factors associated with the excision of deep infiltrating endometriosis, especially the one that is located in the pelvis, when the pelvis is stuck together, when the urethra is involved, when the rectum is involved? So, what are the risks?
See, these are definitely risky surgeries and should be done when they're absolutely, absolutely warranted. Okay, so the risk is worth it if it is going to relieve you of your symptoms, one thing, and if it's going to give you more benefit than cause more harm. Okay, so it's a risk versus benefit analysis that we do. Yeah, definitely when we are doing these surgeries, there are critical organs involved which are stuck together, like the bowel. You could injure the bowel, which may require some form of stapling or excision. The ureters could be injured. But since we have the expertise, we have a way of managing those complications on table without causing significant morbidity to the patient in terms of long-term morbidity. Okay, but this all happens only when a trained personnel is doing it, along with a multidisciplinary team, which involves other specialists also, because they will give you their inputs as to how we can do this in the best manner. So it's like an onboard kind of a meeting where the different specialists, in fact, we have a board meeting before the case. When it's a complex case where the radiologist is involved, the gynecologist, the urologist, the colorectal surgeon, and we take a joint decision as to what is the plan of surgery. So these surgeries are absolutely planned. And I always say in these cases, if we fail to plan, we surely plan to fail. It's very important if you understand the meaning of that. If we fail to plan, we surely plan to fail. So very much applicable in endometriosis surgery. So the risks are there, but obviously in trained hands with a proper infrastructure and with a proper plan of surgery, it's the least.
I thank you so much for that answer. I think it speaks to the comment that's in the chat box about the approach to a frozen abdomen or pelvis. It would be a risky surgery when you find yourself in that situation. But the question is, for instance, if someone does have a frozen pelvis or a surgeon is not able to get into the pelvis, is there an alternative option for someone who may not be a candidate for pelvic surgery? Or have you ever found yourself in that situation where you encounter a frozen pelvis and you struggle to navigate the pelvis to a point where you can't get to the disease to be able to debulk it enough to alleviate the pain? Are there any other alternative options?
Fortunately, I've not been through that situation, but I get a lot of situations where someone has put in a scope. They have been good enough with good intentions to see the severe form of the disease, and they have come out with the scope. And they have referred the patient to a specialist for further management. And that's the best thing you can do for the patient, actually, if you're not equipped to manage the disease, because don't do a half-hearted job. Okay, so you can refer the patient and see, if you're not trained, then don't put your foot into it. The issue is then, how do I train myself? Because somebody has to start at some point. So training yourself is like probably working with somebody who's into endometriosis, watching a lot of stuff on endometriosis, absolutely focusing on endometriosis only and not on everything. That's what I'm mainly an endometriosis surgeon and complex gynae surgeries. I don't do obs, I don't do deliveries, I don't do routine OB-GYN. So I'm just focused on this. So that's why I have that kind of skills now where I can do justice to this patient. So if you can't deal with this, then just come out with the scope, don't do much, and just refer it to a center. And if you're thinking there's any alternative, if the patient is a candidate for surgery, she needs to undergo surgery. There's no other alternative, because nothing else is going to help her pain when everything is stuck and she's severely painful. There's no medical or magic pill that's going to help you. That's only an alibi or escapism for lack of surgical technique.
Noted. Knowing one's limitations is very important. I will open the floor just for 3 questions for now. I saw Ntabi's hand was up. Ntabi, if you're still online, unmute yourself and ask our honorable doctor the question you had.
Hi everyone. I'm Tabi. Thanks for this. I think I'm an endometriosis patient for a very long time now with DIE, and
Mhm.
I asked about. I'm not sure. I got cut off at some point, but I asked the 2 questions about the what are the risks associated, and I think I got the answer to that, and as well as what is your advice to a woman who presents with a frozen abdomen or frozen pelvis, and are there treatment options, or are they just written off as non surgery patients, and rather put on medication? And I want to ask about certain medication as well once you've answered this. Or can I ask about that medication in one go?
You can, if you want to. We can split
Your
the question
thoughts
into
of
two parts.
your thoughts
Yeah.
on medications such as Lyrica being used off label for nerve pain and for in particular endometriosis.
Which medicine did you mention? Please, can you come again?
Lyrica.
Lyrica. It's an.
Lyrica.
Is it allopathic medication, or it's some alternative medicine?
It's Google gives it as a um neuro
Pregabalin. I think
yeah,
it's
Yeah,
pregabalin.
pregabalin.
Yeah. Gabapentin kind of a thing. Yeah. Okay.
Yes,
So I'll answer your first part. I think you spoke about frozen pelvis.
an
Frozen pelvis
abdomen.
is frozen pelvis or abdomen is a very complex. It's a pinnacle of surgery. Okay, surgical
Mm,
basically complexity. Okay.
mm-hmm,
So very few people are trained to deal with frozen pelvis, because even if you see the cancer surgeries, if you see,
mm,
when they are operable cancer surgeries, they are very easy to perform because there's no distortion of anatomy. Okay.
mm.
But when there's a frozen pelvis, everything is distorted. Okay.
Dotted,
You cannot
yes.
make out the planes, and that's why the chances of injury to critical structures increase.
Yes.
But the issue is, when you have to do it, you have to do it. There's no escape, because the patient is symptomatic. You have no choice. You have no other alternative in terms of medication which will release that frozen pelvis. There's no magic wand in your hand. There's no Harry Potter over here. You
Uh,
can just release those adhesions. So nothing. If you need it, if you have to undergo surgery, that's the only choice. The thing is that who is evaluating? Have you approached an endometriosis expert? Now the
uh,
question arises, and what most of my patients and sometimes even doctors ask is, how do we come to know a person is an endometriosis expert? Because there's no subspecialty, there's no special degree to it, and there could be anybody who could claim to be an endometriosis expert. So I
mm,
have a very nice answer to this, which is there on my Insta channel. So Insta channel, I have a lot of these reels on awareness, and all of y'all can access that. So what you need to know is how many years this doctor is dealing with endometriosis.
mm,
I have an entire database of my patients.
mm,
Suppose if Tabi comes to me tomorrow, I'll give you 10 contacts of my patients that I've operated, or even more, so that you can see and speak to them
mm.
about their experience one on one. And
Okay.
I have a YouTube surgical channel where there are, hundreds of endometriosis surgeries. So do your due diligence and
Mm,
research. It's not only me as an endometriologist. I'm not the only one. There are so many other good endometriosis surgeons. You could approach any of them, but do your due diligence and research, and know your doctor
mm,
before you go in for
Go
any
ahead.
kind of opinion. Yes, it's very important. And I don't see many patients doing this, but of late, in the last couple of years, patients have become smart and they know which doctor to go to. Okay, because there could be many. You heard about the incidents in Australia, right? An endometriosis surgeon doing a lot of unnecessary procedures and he got stripped of his license and even his registration got cancelled. He's in jail now. He's an Australian doctor who was doing
Hmm.
a lot of unnecessary endometriosis surgeries. So that's very important that you do your background check on the doctor before you go to the doctor. And I told you the parameters that you need to check: his work, what he's doing, his outcomes in terms of patient satisfaction, the kind of work he's been doing for so many years. So I think that answers the first part of your question, Tabi, right? Am I right about frozen pelvis? Hello, Tabi, are you there?
Yes,
Yes,
yes, yes, you
yeah,
are
I'm
Yeah,
right.
back.
yeah, yeah. And the other part of the question is the pregabalin. Yes, you can
Hmm.
give it for nerve pain. You can give it for nerve pain, but if the nerve is involved or entrapped in endometriosis or fibrosis, you need to release that nerve and then, as a complementary part, give pregabalin, because that pregabalin will not release the adhesion and the fibrosis around the nerve. That has to be surgically excised. And
Hmm.
you saw me surgically excising in my video
Hmm.
the
Hmm.
nerve, the
Yes.
nodule over the nerve. You saw that, right? How we do it.
Yes.
So that only trained people can do it who are very sure about their work. Okay. So
Okay.
that's why. So see, the thing is, you can either have a complete treatment or just a band-aid kind of a treatment.
Yeah.
You have to decide what kind of treatment you want. And that's why it's a shared decision making along with the
Hmm.
patient. So
Hmm.
don't go for the band-aid treatment. Go at the root of the cause and complete the treatment. Otherwise,
I'm
you'll be left
coming
with the
to
band-aid
India.
all the time. You're more than welcome. It will be my pleasure. It'll be my pleasure.
Okay.
If I can just share my screen for a moment, I'll just this next slide is my Insta profile. Am I on the screen now?
Yes,
Uh,
you are.
Yes, yeah.
Yeah, so this is my Insta handle over here. Any one of you who wants to access my Insta handle for any queries, I'm always available. I'm just a DM away. You can. I'm always available to answer your queries in terms of endometriosis. And it's my job, actually. I'm not doing a favor. It's my job. So, and I'd be delighted because this is my purpose in life to, serve endometriosis patients in whatever way I can. So I'll stop. I think everyone has got this. So I'll stop the share over here. And yeah, any more
Thank,
questions, y'all can shoot, no
Um,
problem.
Dr. Hermond,
thank you
I
so
just
much,
have a
Dr.
question. Sorry, Dr. Pule. I just have a question. So,
Yeah,
um, why is it that certain ladies come back and say they've had five, six, or even 10 procedures? Does that mean that the disease was not removed from the root cause and it keeps on coming back?
yeah,
That basically
yeah.
what that means.
So last year I was operating in Kenya, Nairobi. It called me, and I had one patient whom I was operating for the ninth time. Okay. She had undergone 8 previous surgeries. See, it is a recurring disease, even in the best of hands. I say my hands also. I'll tell you what our statistics is around the recurrence after 5 to 6 years or 7 years is around 3 to 4%. Okay. I'll be very frank about that. But around 95 to 96% of our patients are doing good. So if more are doing good, I'm happy with what I'm doing. But this is an endometriosis surgeon who's dedicated and talking to you. Okay. But if you're going to get operated by anybody who is not trained in doing this, then the chances of recurrences are high. And more than recurrences, it is the residual disease. It's not the recurrence, because there's a difference between residual disease and recurrence. Residual disease is what which was left behind in the primary surgery and which is growing now. Recurrence is a de novo recurrence which has happened because it's something like diabetes. You cannot completely remove it from your body. You can only control it. So endometriosis is something similar. So what I'm trying to say, the first surgery of endometriosis of a patient is your best shot against surgical management of endometriosis. So if your first surgery is done by an endometriosis expert who is really an expert, as I told you the parameters to pick up an expert, right? I made it very clear and it's there on my Insta channel also. So if the first surgery is done in the right manner by the right person at the right time, then the chances and the outcomes are wonderful in terms of quality of life, in terms of getting pregnant. But the problem is this does not happen often. More often than not, it's the other way around, that the first surgery is not done well and then things go downhill. And the multiple surgeries are the cause of, more deterioration of quality of life. Because even though I'm an expert, if I'm going to do the surgery on the fourth or fifth attempt, okay, I may not be able to give that kind of an outcome that I would have given when if I would have done the first surgery. Are you getting me? Am I clear? So this aspect is very, very, very important. So in endometriosis, you have to be an outcome-based surgeon, because that is the thing. It's not like a routine surgery. It's a very special surgery where the outcomes matter. So it's very important the surgeon you go to, and obviously the time of surgery. The timing is also important. If you've been delaying your surgery for years, I told you about central sensitization of pain, right? The pain might still be there in spite of me doing a good surgery, because the pain fibers have now formed a proper tract, and you can't disrupt that tract in spite of removing the disease. They're still firing. You understand? So, as I told you, the right time, the right surgeon, the right setup, the right team, everything is of utmost important in this disease called as endometriosis.
Thank you for that answer. It's very comprehensive. Let's move back to the chat. There is a mom, Prudence. She's saying her daughter has been on Visan for almost 7 months, but now,
Mhm.
but she's still in pain. And what is the best pain management she can use?
How old is the daughter?
Prudence, how old is your daughter?
Can I just elaborate on that? Prudence, just let us know how old your daughter is. But I think this speaks to the treatment modalities and knowing when to escalate treatment. So for a mom like Prudence, who has a daughter on Visan for 7 months, and the symptoms are still persisting, when should one escalate treatment? And how does one then escalate treatment? Because I think it goes back to the treatment modalities. What is persisting symptoms? When to escalate? When to seek alternative help? So I think this is what speaking to
Yeah.
treatment modalities that are available and when to escalate treatment. And just to clarify, in terms of the treatment chain, any healthcare professional based on the ACOG guidelines can diagnose endometriosis. But
Yeah.
once you know that you have limited knowledge or limited resources to treat the endometriosis, you need to refer to the relevant healthcare professional. So we have the treatment modalities that are available. If one doesn't work, we escalate to the other. So I'd like Dr. Herman just to explain on that, who to
Yeah.
see, because it's not everyone who has access to specialists, but when do specialists as well refer and when do we escalate treatment? Is Prudence still on?
Yeah, I think Prudence did mention that her daughter is a teenager when we started off. So that's what I'm
Yes.
assuming, that she's a teenager. So
Yeah, she's 16 years old. I was trying to look for the mute button. She's 16.
yeah, no problem. Prudence, I got your question, so I'll try to answer that. So see, she's been taking Visan, which is medical management, for 7 months without much relief in symptoms. Okay, what she needs is a detailed mapping of the disease in form of a good imaging. I would really suggest a good MRI for her to see how much of the disease is there. Now, with medical management, you have to realize the entire concept is based on suppression of estrogen so that the lesions become quiet. But we have to understand these cells are different. Endometriosis cells are different. They are similar to cancer cells. They are not cancer, but similar because they produce their own estrogen. So even if the medical management is there, they can produce their own estrogen. They are self-propagating cells. Okay, they promote their own growth. They resist apoptosis. Apoptosis is something known as programmed cell death. Every cell in your body after a particular time gets replaced. It dies because that is apoptosis. But here there is lack of apoptosis, so those cells keep on growing and invading locally. Now, this form of disease could not be present in everybody. But the fact that when you are refractory to medical management, 30 to 40% of the cases, that means the disease is progressing in some form. So you need to evaluate the disease better. And if it is progressing and invading, then she needs to undergo some form of surgical excision. Okay, I'm not saying that surgery is the only way, but at least she needs to be evaluated whether how much the disease is, a proper endo mapping to see the extent of the disease, and then take a call on surgical excision and post-surgical excision. If I am there, I would keep her on medical management only for 3 to 4 months and then stop it, and then just monitor her on imaging every 6 months to 1 year as to how the disease is. And many of our patients are doing well after this. Yeah. So I'm not saying surgery for all, but definitely for refractory and on medical management, and even a silent disease in 30 to 40%, it will silently progress inside. It will make the disease more complex. Whether you fall in that 30 to 40% is something which only an imaging and a proper monitoring will tell you. I hope I've answered this question. Okay, Prudence, is that enough for you?
Yes, it is. Thank you so much, doctor.
Dr. Koketsu, you have any view on this, or you're okay with what I have said?
I'm okay with what you've said, Doc. I think us as healthcare professionals, we just need to know the importance of knowing one's limitations, knowing when to
Yeah.
ask for help, and knowing
So,
when to delay treatment is very important. And
so just to interrupt you, I have seen patients being on medical management for 4 or 5 years, and the disease progressing, disease progressing and becoming worse, and there's no pain relief. So somebody has just kept them on medical management because they don't know how to do surgery and they didn't want to refer, which I feel is absolutely wrong. And I wouldn't hesitate in saying that's criminal, actually.
it is criminal. And for any
Yeah.
patient, if you are seeing the same doctor and paying so much money, taking the time out of your daily life to go see a certain doctor, and your pain or your symptoms persist with any disease process, you need to reflect and consider seeing an alternative healthcare professional. But us as generalists, general gynaes, we tend to have a network of subspecialists or people who have interest in certain specialities that we refer to. If I see a patient with advanced endometriosis, or I hit a stumbling block, I know when to refer. So whatever field that you're in, always have a network of people, be it endometriosis specialist, your fetal maternal specialist. You have to have a network of people that you work with. If you're going to work in a multidisciplinary team, you have to have an immediate network so that you know who you work with and who you can refer to, and know their credibility, so that when you do refer your patients, you know that your patients are in good hands. So knowing your limitations is very important, and referring patients does not make you less of a doctor or less of a healthcare professional. Knowing your limitation is actually a superpower, because it means that you have self-awareness and you have the best interest of your patients, and that makes
Absolutely.
you a good healthcare professional.
Absolutely.
Are
That's very
there
well.
any more
That's very well said, huh? Dr. Koketsu. Very well said. I mean, you couldn't have said any better. It's really, yeah, it's really hit the nail on the head. It's really nice. Thank you so much for that.
Thank you, Mr.
Dr. Koketo,
Hammond. Okay.
I'm sorry, Dr. Koketo, I'd just like to ask something from a South African perspective. I come from very humble beginnings, and I'm thinking of myself back then when I was 16. Firstly, there wasn't information like this freely available, so this is great. But does the government system have all this in place to treat endometriosis? Because I got my diagnosis from the government system. So I went through the government system, and that's how I then found out what was wrong with me, and then took it from there. So could you just break it down for us? Because I know a lot of people right now are just thinking, okay, Dr. Herman is a private doctor and it's so much money to get to him. First, you have to pay for the plane ticket and then get to India. And what is practical for us in South Africa today, or for the 16-year-old Busi who didn't have medical aid?
The South African healthcare system, I can vouch for it. So everyone goes through the public system because we are required to go through the public system for training. So every good doctor, every endometriosis surgeon, every fertility surgeon in South Africa has gone through the public system. And some of those doctors remain in the academic system, which is in the public system, and some go into private healthcare, and some do both. So you do get very good doctors in the public health system, and that's where we train. There is no good doctor who sprouts from nowhere. But as a healthcare professional, after your training, it's the onus is on us to to take interest in certain specialities or to improve ourselves. So ongoing training, keeping up with the latest evidence and guidelines are important. And your work will always precede you. So the more you do, the more you teach, the more experience you have, the better you become at something. So a person who just started endometriosis a year ago can definitely not be better than someone who has been doing it for years. But we start from somewhere, and ongoing training and keeping up with the latest guidelines and training is very important. So in simple terms, the public health system does have good endometriosis surgeons that I know of, and I can tag them on my page with their permission. But within our practice, we have referral pathways that we have based on the people that we work with. But the public system can work well, even though the comfort is not the same. There are long waiting lines, but the help is there. The help is there, the expertise are there. But the problem with the public health system is that the patient to doctor ratio, one has to understand, is very skewed, is very limited. So it's not everyone who has access to private healthcare because of how expensive it is. But the bottom line is that there are experts in the public system. It's just that the patient to doctor ratio is very small.
Okay, there's
So
another question.
Busi, as she mentioned, the collaboration is very important. Even if you are a junior surgeon, if you collaborate with somebody who's experienced, you also learn, and the outcomes are also, better. And she's put it very nicely. For us in India, it's mainly private based. But believe me, I never refuse a patient on the basis of money. I operate on everybody. I'm very flexible on that. So we keep it very flexible depending on what the economic status of the patient is. And I even operate free of charge at many places, absolutely free of charge. When I know the patient is like below poverty line, it's absolutely free. I don't take a single money. So it's basically you cover up by doing good number of cases. So it's okay. Doesn't matter actually.
Wow, Dr. Herman, wow. Thank you. I salute you for that. Wow.
It's a job. It's a job. It's nothing. We're not doing a favor. It's just a job. So we should be doing it.
I think the patients, the endometriosis patients, can officially call you an ally. Yes, thank you for being an ally in this journey.
Pleasure. It's my pleasure. Thank you.
There's a question. Leonie was asking that she had stage 1 endometriosis 15 years ago. And are there chances basically of the endometriosis stages increasing with the years?
Yeah, that question is for me, right?
Yes,
Yeah.
Dr.
Okay. So when you have stage 1 endometriosis now, there are a couple of scenarios that can happen. The disease might either remain the same, like in 10 to 20% of the patients, it may remain the same. Okay. So you just need to keep a symptom diary and keep an account of your symptoms as to whether they are worsening or they are the same. It is unlikely that the disease will disappear away completely. It's very unlikely. It will either remain the same or it will progress. As I told you, in 30 to 40% of the cases, it can progress. So if it progresses, definitely it can silently progress also. The best way to do a guided ultrasound every year, if you have stage 1 disease, not an MRI, not required, a good ultrasound should be good enough. And if your symptoms are, definitely progressing at a faster rate, then probably you need to do an MRI to see and to map the disease. I think apart from that, you don't need to do anything else because there's no blood test or biomarker. A lot of people believe CA125 at one point was a marker, but it's absolutely a non-specific test, CA125 blood test. That's for basically ovarian cancer, not for endometriosis. So I think just keeping a symptom diary and monitoring yourself with imaging every year should be good enough. And if you have any, I don't know what age you are at, but if you have any fertility goals or anything, you should complete it as soon as possible.
Thank you so much, Dr. Herman. I think I think we're going to wrap up. We're coming to the end. So anyone who has any other questions, you can raise your hand or just write it in the chat. But Gifilwe sent a question in the chat, and she was asking if having period pains 2 weeks prior to her actual period can be a symptom of endometriosis, Dr. Herman.
Yeah, even you can have it during your periods, and in between periods also you can have your pain of endometriosis. That's known as chronic pain in abdomen. So any pain in the pelvis which is out of proportion, or which is debilitating, which is very severe, irrespective of what that pain is, it needs to be investigated.
Um, and another question I have is you speak about your patients doing well. What lifestyle changes did they have to do? What are they doing to maintain their healing after
Yeah,
surgery?
so some of them we have nutritionists on our board. Okay, they are into functional medicine also and nutrition regulation also. So we do put them on. We do get them connected to them, and they are managing them quite well. Obviously, lifestyle minor changes like exercises and basically diet is good enough. Nothing specific in terms of complementary treatment that we do. See, the kind of patients that come to me are for surgery, basically. So I am surgically excising and following them up. My fellows, they call them every 6 to 8 months over a phone call and just a small questionnaire about the quality of life we are trying to maintain. And that is how we realize most of our patients are doing well. You can't have 100% result, that's impossible. But definitely, most of them have a reduced pain score, like the pain comes from 7 to 8 to 1 to 2 or even less than 5, which again I think is a victory because a patient can lead a good quality of life. And most of our patients that we operated, say 7, 8 years back, are just coming basically for removal of uterus or something once they have completed their child bearing, and they have had a good quality of life for 7, 8 years. They're having adenomyosis now. And when we go back inside, the scene is not as bad as it was during the primary surgery. So we are quite happy in those terms as far as our outcomes are related. So what I'm trying to say in endometriosis, you need to follow the principle of precision surgery because it's a very big, it's kind of a tightrope where you need to do a balancing act. So it's known as economic radicalism, where you're supposed to be radical towards the excision of the disease, but maintain economy towards the function of organs because these are young patients. You can't have a deficient bladder or a deficient bowel after surgery. And our principle and philosophy is, as far as possible, don't give a problem to the patient after surgery if she never had before surgery. Don't give an additional problem. So that is the philosophy we work with, and that's how we try to do the balancing act on the tightrope, which comes with experience. This is a lot of surgical wisdom also involved in endometriosis surgery. It's not just like go inside and start cut, 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 cut. You need to have a lot of surgical wisdom. You need to think of the patient as a whole and not just the pelvis. Okay, you need to have a holistic 360-degree approach.
Thank you so much, Dr. Herman, for this very
My
informative session.
pleasure. Yeah, it's been almost 2 hours, and I'm
Yes.
really happy that we could pull it off.
Thank you so much.
So,
Could you please give us closing remarks? What would you like to leave with us? What would you like to say
so
to the doctors online and the patients?
first to the female patients, don't take your symptoms lightly. Don't neglect them. Females are usually, they brush things under the carpet. Most of them have a high threshold and they are very much into their, other parts of life and not really focused on their health, at least in our part of the world. So don't neglect your symptoms. Get an early evaluation. Seek the opinion of the right experts. Search for them. You'll get it. Many of them are very accessible. Like me, I'm just a DM away, and there are many more like me. You can just get in touch with us for an initial evaluation whenever you feel something. We are always there. Whenever we are free, we answer our the queries. And if something is required, you go on scientific data. Okay, not just on hearsay. Go on scientific, do your due diligence, speak to patients who have already been through this, what was their experience, and then take a shared decision along with your doctor as to what you want. So, this is very important. For our medical professionals, obviously, do not dismiss symptoms. Okay, again, the right management at the right time by the right person. Do not hesitate in referring the patients, and those of you interested in learning endometriosis surgeries are more than welcome to contact people like us who are doing it. We are more than willing to share our knowledge, because see, we can't cater to the whole world, right? Ultimately, we have to pass on knowledge so that more number of patients in all parts of the world get benefited. So this is the entire reason why I'm over here today, to create some form of an awareness and what I can contribute from my side. So it is difficult surgery, but it's not impossible to learn. And I really feel more and more people should start doing proper endometriosis surgery. Mentioning the word optimum proper endometriosis surgery. It's very important because we see a lot of patients coming back again and again. So if you put the effort, you'll be there. So I wish you all the very best, and thank you so much, Busisiwe, for this invitation, for getting in touch with me, for all this effort, for this initiative, and Dr. Koketso for giving in your inputs. And it was nice knowing you. And to the entire South Africa, it was really a pleasure interacting with all of you. Thank you so much.
Thank you so much. And Dr. Koketo,
Thank you.
what are your
Thank
closing
you.
remarks for us?
Thank you so much, Dr. Hammond. I will definitely stay in touch with you. As I said, I'm working with Figo on the minimally invasive surgery committee, and we're working actually, where we're working to collaborate with everyone within the African continent to advance skills within our trainees and young consultants in terms of minimally invasive surgery and endometriosis. So I look forward to the collaboration, and in
My
future,
pleasure.
hopefully for the healthcare professionals online, I will look into organizing a webinar with Dr. Herman and other professionals that he's working with for a webinar tailored for you. And thank you so much to everyone who took the time, the whole 2 hours, to attend this webinar with us. And I hope it was informative, empowering. And if there are any more questions or suggestions in terms of topics that you think we should discuss in future, please DM me or Busi. But we look forward to working with Dr. Herman on other projects. So thank you to everyone, and do rest
Thank you
well
very
when you
much.
do.
Well, thank you both for a lovely session. Okay. Thank you both for a lovely session, and to
Thank you.
our attendees, our patients, our doctors and partners and friends, sisters, brothers, everyone who's here to support their loved ones. Thank you so much for coming in and just learning and being part of this movement that we've started of awareness. And I hope it was quite informative and that you've learned a few things that you can practically implement even starting tomorrow. So thank you so much. and good night. And thank you so much, Dr. Herman. I do appreciate that
Thank
it's
you.
almost
Thank
midnight
you.
in India. Thank you
Yeah,
for staying up with us.
it's past midnight. It's the next day. It's 15th April over here. So, but anyways, I'm
So
okay.
thank you so much for
I have to
this.
wake up at I have to wake up at 6 o'clock and go for an endometriosis surgery in the morning. But that's okay. I'm very happy that I this was
Thank
time well spent, and it was a
thank you.
great
Thank you so
opportunity.
much.
Thank you.
Thank you
Thank
so
you,
much.
everyone. Hope to see you
Thank you.
guys
Thank
soon.
you. Good
Thank
night.
you.
Good
Bye-bye.
night.
Bye-bye.
Good
Good night.
night.
Bye.
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 Bye.